Hello, my name is Julie Dagum, and I'd like to present to you some information regarding migraine headaches and the medications used to treat them. As an overview of the presentation, we'll go through some of the background and diagnosis of migraine headache, go through the pathophysiology, talk about preventative versus abortive therapy for migraine headaches, discuss the common agents used to treat migraines, and we'll end with a few patient scenarios. The objectives of this presentation are to be able to describe the pathophysiology of migraine headaches, to define the difference between preventative and abortive treatments of migraine headaches, and to list the common side effects and precautions associated with preventative and abortive migraine headache therapies. The peak incidence of migraine headaches typically occurs between early to mid-adolescence, and the one-year prevalence is 6% among men and 15 to 18% among women, so it's more common in women versus men. In addition, patients who are affected by migraine headaches are typically people without other concomitant medical conditions. They may be coworkers, they may be friends, or they may even be you. Migraine headaches can be as debilitating as many other disease states in terms of days lost of work, etc. In fact, the World Health Organization rates somebody who is suffering from an active migraine headache to be as severe as somebody who is suffering from quadriplegia, psychosis, or dementia. An important distinction to make is that migraine headaches may occur with or without aura. Migraines without aura are defined as at least 5 attacks fulfilling the following 3 criteria. Attacks that last 4 to 72 hours, either treated or unsuccessfully treated. Attacks that include 2 or more of the following symptoms: unilateral pain, pain aggravation on movement such as walking or stairs or routine physical activity, throbbing or a pulsating quality to the pain, and moderate to severe in intensity, enough to inhibit or prohibit usual daily activities. It also includes one of the following symptoms: nausea or vomiting, photophobia or phonophobia. Migraine with aura is diagnosed from at least 2 attacks. The aura and subsequent headache that follows has at least 3 of the following 4 characteristics. Number 1, the aura symptom or symptoms are completely reversible. Number 2, at least one aura symptom develops gradually over more than 4 minutes, or 2 or more symptoms occurring in succession. Number 3, no single aura symptom lasts longer than 1 hour. And number 4, the headache that follows within 1 hour of the aura resolution, or the headache may actually proceed or begin simultaneously with the aura. In addition, in order to make the diagnosis of migraine with aura, there has to be no evidence of organic disease. This slide shows a simulation of migraine aura, and this would be in somebody who has a visual aura along with their migraines. The simulation of the migraine occurs on the left side, and the normal color vision is on the right side of the slide. In order to make the diagnosis of migraine headaches, it has to be noted that migraines are distinctly different from cluster headaches. Characteristics of cluster headaches when compared with migraine headaches are that cluster headaches predominantly affect men, whereas migraine headaches predominantly affect women. Cluster headaches are also shorter in duration than migraine headaches. Cluster headaches typically are lasting between 15 to 90 minutes. Cluster headaches also can occur more frequently than migraine headaches. In some cases, cluster headaches could occur 1 to 3 in a single day. Cluster headaches are also not associated with nausea, vomiting, or any visual symptoms, but they are associated with lacrimation. Different tools exist that attempt to quantify migraine headaches and its disability. The MIDAS questionnaire is just one way of translating subjective data into an objective score. Subjective assessments may include questions such as, on how many days in the last 3 months did you miss work or school? Or how many days in the last 3 months was your productivity at work or school reduced by half or more? How many days in the last 3 months did you not do household work? How many days in the last 3 months was your productivity in your household work reduced by half or more? And how many days in the last 3 months did you miss family, social, or leisure activities? The numbers are totaled into a score called the MIDAS score, and then are translated into a disability rating. The severity and frequency of migraines should also be assessed. This can be done by quantifying the number of headache days in the last 3 months and rating the pain using a scale of 0 to 10, where 0 is the worst, 0 is no pain, and 10 is the worst pain imaginable. There might be several different triggers that patients might experience for their migraines, and triggers can vary from patient to patient. Some of the common migraine triggers reported include lack of or too much sleep, irregular meals or diet, which includes alcohol, caffeine, chocolate, monosodium glutamate, tyramine, or nitrates in the diet, irregular exercise, either too much or too little, strong odors such as perfumes or fumes, stress or post-stress, menstrual cycle changes, environmental causes which might include noise, weather changes, high altitude, glare or lights, and flickering. And some medications can even be a trigger to migraines, including trazodone, oral contraceptives, and others. The pathophysiology of migraine is a complex interrelation of a migraine trigger, which causes neural dysfunction, activation of the trigeminal nerve, vasodilation of intracranial blood vessels, and ultimately stimulation of nerve pain pathways. The graphic on this slide actually demonstrates how the migraine disorder is caused by a stimulation of the trigeminal nerve pain pathways. The trigeminal nerve innervates numerous areas of the head, face, and neck, and this may be one reason why migraine pain can affect many areas of the head, face, and neck. In migraine, intracranial extracerebral blood vessels are vasodilated, causing stimulation of the trigeminal nerve. The vasodilation may be caused by local inflammation. The dilated blood vessels cause blood to be rerouted into the venous circulation, which can bypass the tiny capillaries. The pain of migraine is due to cerebral hypoxia and ischemia that results from the rerouting of this blood. The dilated blood vessels are also activated to release the inflammatory peptides, including substance P and calcitonin gene-related peptide. These peptides stimulate trigeminal fibers that sense pain. They also cause plasma extravasation, which is vessel leaking, and further the inflammatory response in the dura mater. This activates pain receptors. The pain response is then conveyed to the trigeminal nucleus caudus in the brainstem and to higher brain centers. Thus, anti-inflammatory medications reduce the inflammation and vasoconstrictor medications reduce vascular leakage and extravasation, but we'll talk more about this when we get to the medications used for migraine. The graphic on this slide shows closer that serotonin also plays a role in the pathophysiology of migraine. We'll cover this more when we discuss the triptans, which are medications that are selective serotonin receptor agonists. There are two strategies that are used to treat migraine headaches: abortive therapy and preventative therapy. Abortive therapy is medications that are taken as needed to treat an acute attack and to abort the attack from occurring. Preventative therapy is medications that are taken every day, and essentially these medications work to reduce the frequency and severity of future migraine attacks. The goals of therapy for abortive treatment would be to have something that works rapidly and consistently with no headache occurrence. They restore the patient's ability to function. They minimize the use of the need for rescue medications, and essentially optimize self-care and reduce further use of resources, something that's very cost effective, and something that has minimal or no adverse effects. The goals of treatment when using preventative medications include reducing the attack frequency, severity, and duration, improving the response to the treatment of acute attacks, improving function and reducing disability from migraines, something that's cost effective and again has minimal or few adverse effects. The decision to start preventative therapy should be based on several factors. Frequent headaches with substantial disability, defined as greater than 2 per month that produce disability lasting 3 or more days. Contraindication to failure or overuse of abortive treatments. Presence of an uncommon migraine condition such as hemiplegic migraine, migraine with prolonged aura, or migrainous infarction. And in addition, patient preference. Costs of preventative and abortive therapy and risk of side effects should also be considered. Again, there are many factors to consider before starting medication therapy in a patient. First of all, compliance should be at the top of the list to consider. A medication may not work in every patient, but it definitely will not be effective if the patient will not take it. Noncompliance may occur in a number of situations. Some examples for noncompliance may include frequency of dosing, cost, route of administration, or perhaps the patient is searching for other types of medications, such as narcotics, and is not satisfied with the medication selection. Involving the patient in medication selection can improve compliance. Previous medications and determination of dose optimization without side effects is important in determining if a medication has been tried and is truly ineffective or could be rechallenged. A complete list of current medications, both for headache and for other conditions, is very important. Several different key evaluations can be made from this. It should be determined whether the current medications for headache management are being optimized and whether the patient is experiencing efficacy or toxicity from the medications. A current list of medications may also provide information regarding whether analgesic use is actually precipitating the headache. The evaluation of other current medications may identify medication interactions or whether a patient is taking a medication that may precipitate headaches, such as trazodone, nitroglycerin, hydralazine, H2 receptor blockers such as ranitidine or famotidine, or oral contraceptives. Another consideration before starting medication therapy is a patient's concurrent medical conditions. Perhaps a patient is already taking a medication that can be used for the prevention of headaches for another reason. For example, a patient may be taking Prozac for depression, but this medication may also be beneficial in preventing their headaches. On the other hand, a patient may suffer from hypertension, and an antihypertensive medication may be useful to prevent headaches while also addressing the problem of hypertension. Some medications may be avoided in patients with certain medical conditions. In a patient with a history of an eating disorder, the use of Depakote for migraine prevention would be avoided since this medication can cause significant weight gain. Another concern is if the patient is pregnant, as most of the medications need to be avoided in pregnancy. Type, description, triggers, and symptoms of headaches are all important to determine if a headache might be responsive to medication and if concurrent symptoms also need to be treated with ancillary medications. The bottom line is that the whole patient should be treated, and medications are only one component in the treatment of the whole patient. We will now focus on the medications used to treat headaches. We'll start with a discussion of the medications that have been used for the acute treatment of headaches. The agents are for the most part very different from those used for the prevention of headaches. Medications for acute attacks are taken on the onset of the headache in an attempt to stop or abort the attack. These medications are not intended for regular or daily use. This practice can cause medication-induced headache, and this type of headache generally requires the discontinuation of medication. In general, the goal of treatment is to reach maximal improvement in headache pain and symptoms by using the least number of medications at the smallest doses that achieve this. Nonsteroidal anti-inflammatory agents, or NSAIDs, are a class of medications that have been proven to be effective versus placebo. The agents in this class that have the most evidence for efficacy include aspirin, ibuprofen, naproxen, and combinations of acetaminophen, aspirin, and caffeine. The NSAIDs as a class are effective due to their analgesic and anti-inflammatory properties. Although caffeine is not considered an NSAID, there are several formulations of combinations of a particular NSAID with caffeine. Caffeine also has anti-inflammatory and analgesic properties, which are additive when used in combinations with an NSAID. This allows for lower doses of NSAIDs to be used. Because these agents are available in an over-the-counter form, patients have easy access to these medications. They are also relatively inexpensive, and many are available in a generic form. Because patients find these medications easily accessible, it is important to emphasize the correct use of these medications to avoid side effects. Each person may have a different response to each medication in this class. Because of this, the failure of a patient's headaches to respond to one medication in this class has no bearing whether the headache will respond to another agent in this class. Treatment failure due to lack of efficacy to one agent does not predict lack of efficacy to the class of medications. Concerns with the NSAID and caffeine therapy include the potential for medication-induced headaches if used too frequently. Then the potential exists for rebound headache to occur if the medication is withdrawn. As a general rule, these medications should be taken at the earliest stage of a headache and not taken for more than 3 days a week to minimize the potential for problems including side effects and medication-induced or rebound headaches. In addition, the use of these agents carries the serious risk of abdominal discomfort and gastrointestinal ulceration. Agents in this class can also cause renal failure. Patients with heart problems such as hypertension and congestive heart failure should not take these medications as they can cause fluid and salt retention. These risks are even more significant when you consider that patients may be taking these agents without the knowledge of their physician. Moving on to the next class of medications used to treat acute attacks of migraine headaches, the triptans have been shown to be effective and have gained significant popularity in the treatment of this condition. The agents in this class of medications are all available by prescription only and include amitriptan, elatriptan, frovatriptan, naratriptan, rizatriptan, sumatriptan, and zolmitriptan. Each of these agents act as agonists at the 5-hydroxytryptophan 1B and 1D receptor subtypes. Activation of the 1B subtype is thought to cause vasoconstriction and alleviate migraine pain, and activation of the 1D subtype inhibits inflammatory neuropeptide release and reduces transmission in pain pathways, including the trigeminal pathway. It is thought that the triptans exert their action through varying degrees of agonist activity at these receptor subtypes. Each agent has a different affinity for the 1B and 1D subtypes, as well as activities at other serotonin 5-HT1 receptor subtypes. These differences generally have not been shown to be clinically significant. One of the foremost cautions with triptan therapy is the risk for medications in this class to constrict coronary arteries. Because the 5-HT1B receptor subtype is expressed on coronary arteries, it is thought that agonist activity at this particular subtype may be involved in this effect due to the vasoconstriction effects of the triptans have at this subtype. It has been thought that the triptans have minimal activity at this receptor subtype, may not demonstrate this effect, and post-marketing data indicate that clinical events are rare. Despite this, it is always prudent to use all the agents in this class with caution, if they are even used at all, in patients with risk factors for a documented history of ischemic heart disease, cerebrovascular syndromes, or peripheral vascular disease. This would include syndromes such as angina, myocardial infarction, silent ischemia, underlying cardiovascular disease, stroke or transient ischemic attack, ischemic bowel disease, or uncontrolled hypertension. Another interaction with this class of medications is concurrent administration of medications that inhibit monoamine oxidase inhibitors. Most of these medications in the triptan class are metabolized by MAO subtype A, and therefore the triptans interact with medications that inhibit MAO. In addition, it is important for patients to understand that the triptans are to be used as soon as possible after the onset of a headache and are used for acute attacks only. The triptans are not to be used for prophylactic use. Dosing limits should be enforced with these medications to prevent medication-induced headache, which can result in daily headaches. When determining which triptan would be appropriate in a patient, differences in pharmacokinetic properties such as onset of action, duration of action, and route of metabolism should be considered. For example, some medications in this class are metabolized through the liver's cytochrome P450 system and may be a cause of drug interactions. It may be wise to avoid these agents if the risk of interaction exists, or if the patient has liver disease. Medications in this class that are predominantly excreted in the kidney would be avoided in patients with renal disease. Not only do differences in pharmacokinetic properties help distinguish the medications in this class, but also dosage formulations differ. For a patient suffering from nausea and vomiting as part of their headache presentation, a nasal or subcutaneous dosage form may be beneficial. All these factors together are considered when deciding upon the best medication to choose for a particular patient. Medications belonging to a class of medications called the ergotamines are very effective in the treatment of migraines. There are many formulations of these medications available, including oral, sublingual, intranasal, rectal, and injection for IM or IV use. The ergotamines treat migraine headaches through a number of possible mechanisms. They are structurally related to amines such as norepinephrine, epinephrine, dopamine, and serotonin. Ergotamine is a potent vasoconstrictor, possibly through effects on serotonin receptors. Although it can also produce vasodilatory effects, depending on the degree of resistance of the vasculature, ergotamine most likely produces vasoconstriction selectively in arterial cranial vessels. Dihydroergotamine may have additional beneficial effects by working through more of a central mechanism. It can block alpha-adrenergic receptors, which exerts a direct vasoconstrictive effect on peripheral smooth muscle and cranial blood vessels that are dilated during a migraine. This can decrease the pulsing pain that can occur. These medications can cause tachycardia and elevated blood pressure. Because of vasoconstrictive effects, these medications should not be used by patients with chronic cardiac disease, peripheral vascular disease, or hypertension. Severe nausea is also a dose-limiting side effect and should be treated with antiemetic medications. Nausea should be regarded as a sign of long-term toxicity. Long-term toxicity may present as nausea, vomiting, headache, malaise, and vasoconstriction of limbs, which may lead to gangrene. A danger with the long-term use of ergotamines is ergotamine dependence. This can occur if these medications are used more than 3 times per week for an extended period of time. Ergotamine dependence is a form of medication-induced headache and is characterized by more frequent and severe headaches that are unresponsive to usual doses of ergotamine and is called ergotamine rebound headache. Discontinuing the medication causes severe withdrawal or rebound headache, but increasing the dose perpetuates the cycle by providing transient relief. Daily use of analgesics or opioids can cause the same tolerance, and depending on the cycle, it therefore is important to appropriately treat these patients. We'll just briefly mention opioids. Although this class of medications is well recognized for therapeutic utility in many pain syndromes and conditions, the only medication in this class with good evidence for efficacy in the treatment of migraine headaches is butorphanol nasal spray. Opioid medications can be used by experts familiar with their appropriate use. In general, however, the use of these medications in migraine headaches is reserved for when other medications fail. The use of opioids carries a risk for medication dependence and rebound headache upon withdrawal of medication if the opioid is used inappropriately. Opioids are also associated with side effects such as nausea, vomiting, drowsiness, and other effects. These effects typically diminish with continued use in chronic pain conditions. In the treatment of headaches, however, these medications are not used chronically or on a daily basis, so these side effects may be more bothersome because patients do not adjust to the side effects as easily. In addition, constipation is a major problem that must be treated and does not diminish with continued use of opioid medications. Some antiemetic medications have been used for the treatment of migraine headaches. In general, the only agents to demonstrate efficacy have been metoclopramide in the IV form and prochlorperazine in the IV, IM, or rectal form. These agents have limited utility, and the ideal candidate for this approach is a patient with severe nausea and vomiting who also needs a sedating side effect to their treatment. Isomethoptane and combinations such as Migraine and Duradrin in general have shown borderline efficacy in the treatment of migraine headaches. Finally, although corticosteroids have been used in the treatment of migraine, they are generally thought to have a lack of efficacy with long-term use. The chronic use of corticosteroids also carries the risk of side effects such as increased blood pressure, changes in fat metabolism, diabetes, mood swings, osteoporosis, and so on. We will now switch gears to the use of medications to prevent migraine headaches. The goal of therapy in this case is to raise the threshold for onset of a migraine. Essentially, this means that the frequency or the occurrence and potentially the severity of a migraine that does occur would be reduced. One key thought here is that the etiology of the headache is important in deciding if a patient is a good candidate for prophylactic treatment. If the headache is determined to be a medication-induced headache occurring as a result of the overuse of analgesic medications, ergotamines, or other medications for the acute treatment of headaches, then it is unlikely that a preventative medication would be effective. The effective treatment here is to break the medication overuse cycle. If a patient is appropriate for preventative treatment, then, as we talked about previously, concurrent medical conditions may need to be considered in medication selection, as many of the medications may be useful or avoided in certain medical conditions. Side effects and adverse events must also be considered. One general rule with all the prophylactic medications is that the dosing range can be very broad. The medications used for preventing migraine headaches are started at low doses and gradually increased every 2 to 4 weeks. This is continued until either the medication works or side effects prevent dose escalation. A challenge with this is that patients tend to give up on medications prematurely, thinking they are not working, when they are still in the titration phase. An adequate trial of at least 2 months should be allowed before determining if a medication is working. A headache diary is also helpful so that the response to medications can be determined. For the rest of the talk, we'll briefly touch on the classes of medications that have been used in the prevention of migraine, and discuss the medications that have shown to be the most efficacious in their class, as well as their side effects. Keep in mind the concerns that could be associated with each medication, as we will not specifically discuss each concern, but rather give a brief overview of each class of medications. Again, many other medications other than the ones we will discuss have been used, and each patient's response to a medication can vary significantly. Because of this, the following slides include some of the most common medications used to prevent headaches, and are not considered a comprehensive discussion of all possibilities. Several classes of antihypertensive medications have been used in the prophylaxis of migraine headache. Of the beta blockers, propranolol, metoprolol, timolol, atenolol, nadolol, pindolol, and acetylol have been studied, with overwhelmingly most trials occurring with propranolol. Propranolol and timolol have been shown to be efficacious, while trials with other agents have mixed results. The calcium channel blockers nimodipine, nifedipine, verapamil, and nicardipine have been studied, all of which show some efficacy but not overwhelmingly so. Clonidine and guanfacine are alpha-2 agonist medications. Clonidine seems to be as efficacious as placebo, but guanfacine showed moderate results in one trial. Overall, evidence seems to indicate that propranolol and timolol may be the most effective of all the antihypertensive medications, and this may be due to non-selective beta-blocking actions. Side effect concerns with propranolol include fatigue, depression, nausea, and dizziness, and exercise intolerance. The same side effects are concerning with timolol. Several antidepressant agents, including amitriptyline, clomipramine, fluvoxamine, and fluoxetine, have been studied for the prophylaxis of migraine. The only agent to demonstrate consistent efficacy is amitriptyline, typically used in doses of 30 to 150 milligrams daily. Side effects that may be a concern with amitriptyline include drowsiness, weight gain, and dry mouth. Of the anticonvulsant medications studied for prophylaxis of migraine headache, divalproex has shown the best results, and a formulation of this medication has actually been approved for migraine headaches specifically. Potential side effects of divalproex include weight gain, hair loss, tremor, and liver problems. In addition, there has been some success with topiramate. Topamax is a medication that actually does now carry labeling for migraine headaches, and potential side effects with Topamax include weight loss, word-finding difficulties, and cognitive slowing. The NSAID naproxen has shown a modest effect on headache prevention. Side effect concerns are the same as discussed in the acute treatment of migraines, including GI bleeding, renal failure, and fluid and salt retention. Other agents that have been studied include magnesium and riboflavin supplementation. The herbal agent feverfew has also been studied. These approaches may show some efficacy in certain circumstances, but there are many factors to consider before deciding if these approaches are appropriate. Pharmacy technicians and pharmacists can serve as important triage people in terms of the role of the management of migraine headaches. I wanted to give a little bit of background on this in that in many cases patients might find the pharmacist a very accessible healthcare provider. Many patients suffering from migraine headaches may not be seeking formalized care for their condition. These are the people that suffer from migraines and deal with their condition themselves. They may sit in a dark, quiet room. They may reschedule appointments, break plans, and miss work. Then they go to the pharmacy to buy a variety of different over-the-counter medications and self-medicate themselves with ibuprofen, Excedrin, pseudoephedrine, and any number of sinus formulations. Pharmacy technicians and pharmacists may be able to identify the patient that is purchasing these medications and question the patient as to why they're purchasing the items. In this way, patients who may need more extensive evaluation of their condition can be identified. In addition, patients may find that the pharmacy staff are among the easiest healthcare professionals to access, since they are out there in the community working at 24-hour locations, always answering the telephone. You get the idea. Because of this accessibility, patients may ask pharmacy staff members questions that may trigger a recommendation for a change in therapy or that a patient should make an appointment with their healthcare provider. If a patient always uses the same pharmacy to have their prescriptions filled, then their medication profile at that pharmacy is complete. This would be ideal. Even without a complete medication profile, however, it may be identified that a patient has tried several different prescription medications for headaches. These prescriptions could be from several different physicians who are all unaware of the other medications that the other prescribers are prescribing. This may lead to the discovery that the patient is suffering from these headaches and is trying all strategies by getting different prescriptions from different healthcare providers. This may lead the patient to be directed to find different treatments by a team of specialists, such as a headache clinic. In the same way, the pharmacy staff members can identify concerns and direct them to appropriate healthcare providers. This might include identification of medication interactions, allergy screening, duplication of therapy, patient compliance based on refill history, and potential inappropriate use or misuse of medications by patients. Pharmacy staff members can also provide education to the patient regarding expectations for medications, possible side effects, and instructions for titrating or tapering medications, as well as with dosing and available formulations of products. The following scenarios illustrate situations related to the treatment of patients with migraines that you may encounter in your practice. Scenario number 1 is you are working as a triage nurse at a primary care clinic. A middle-aged male who is a regular patient at your clinic calls today saying he needs a prescription for his sumatriptan because he has no more refills. When you look back at his chart, you see that he has prescriptions for sumatriptan 50 mg tablets number 9, and divalproex ER 500 mg tablets number 30, each with 3 additional refills, and they were called into his pharmacy on January 31st. You call the pharmacy to determine why he is out of refills, and the pharmacist tells you that the patient's recent medication refill history includes sumatriptan, and back in January was the last time he received divalproex and sumatriptan as well. What is your assessment of the situation? Which medication is used for abortive treatment of migraines? Is the patient on a medication to prevent migraines? In this case, the assessment of the situation might be that the patient is overusing his sumatriptan and not using his preventative medication, his divalproex, since he got that filled on January 31st and he only got a month's supply of it, and it's already 2 months later. So, the medication used for abortive treatments of migraines, he's using the sumatriptan. Is the patient on a medication to prevent migraines? Yes, we've placed him on divalproex ER, but the question is whether or not he's compliant with it. So perhaps he's not being compliant with his divalproex, and that leads to him requesting further refills of his sumatriptan. He may not understand what it is that he needs to take the medication for, he may not understand how to take it, or he may be experiencing side effects from the divalproex that make him not want to take it and rely more so on his sumatriptan. In any way, these issues can be addressed. In the second scenario, you are working as a nurse on a post-surgical floor at a large hospital. Your co-worker, who is a middle-aged female, asks if you will cover her patients for a few minutes while she runs to the pharmacy to purchase a bottle of ibuprofen. As she is leaving, she mentions she wishes your pharmacy carried Excedrin because lately even ibuprofen won't make this headache go away. What is your assessment of the situation? What type of headache might your coworker be suffering from? In terms of the assessment of the situation, this might be a situation where your coworker is self-medicating herself with various over-the-counter products. Her statement in terms of mentioning that she wishes the pharmacy carried Excedrin because lately even the ibuprofen won't make the headache go away could indicate that perhaps she's using the ibuprofen significantly enough in order to be suffering from a medication-induced headache as opposed to the original headache that she was suffering from. In this case, you may want to question your coworker to see if she is taking her medications appropriately, and you may want to suggest that she seeks medical attention from a provider who would be able to more appropriately treat her headache and determine whether or not she needs a different type of an abortive therapy and if she would be a candidate for a preventative type therapy. So with that, that concludes the presentation on migraine headaches. I hope that you found it interesting and helpful. Thank you very much for your attention.